Hello everyone and welcome to our second video on renal physiology. All the items listed on this slide are measurements that are obtained to determine how well the kidneys are functioning, and we're going to talk about how all of these measurements are obtained for a given patient's kidneys. So the first measurement is the most important. That's the glomerular filtration rate. This is how much liquid passes through the filter, i.e. the glomeruli of the kidneys. So we want to measure the total flow rate of fluid going through all the glomeruli in the kidneys. Second measurement is the renal plasma flow. This is how much liquid the kidneys handle. So in other words, how much liquid goes into all of the glomeruli in the kidneys. We can also measure the filtration fraction. This is of all substance X entering the kidney, what percent gets filtered, and we'll talk more about that in a minute. And then finally, we'll talk about renal clearance, which is a measurement of how much of each blood component gets removed, and it's calculated in an unusual manner, so we'll talk more about that in this video. On this slide is a drawing that I'll refer back to throughout this video. So this is a glomeruli, and what we've got is the renal plasma flow is the blood flowing into the glomeruli, and the renal plasma flow represents the sum of the flow into all the glomeruli in the kidneys. The GFR is the glomerular filtration rate, and this represents the sum of the flows of all the fluid going across all the glomeruli in both kidneys. And then finally, we have the urine flow, which is the amount of fluid flowing out of the kidneys after it has been filtered by all the nephrons in the kidneys. This can be easier to understand if we put some actual numbers in. So let's imagine that the renal plasma flow is 5 liters per minute. This is the total volume flow of fluid into all the glomeruli in both kidneys. Let's further imagine that of that 5 liters per minute, 2 liters per minute crosses the glomeruli and enters the nephrons. Then the GFR would be 2 liters per minute. And we could also calculate a filtration fraction for the kidneys. The volume that is being filtered is 2 liters out of a total 5 liters coming in, and that gives us a filtration fraction of 40% for both kidneys. We could also calculate some numbers for a specific solute in the plasma. So for example, if we go back to our measurement of GFR of 2 liters per minute, let's suppose that that GFR is made up of 2 grams per liter of sodium. We could then calculate what's known as the filtered load of sodium. This is how much sodium is passing through the glomeruli and entering into the nephron. That filtered load would be 2 liters per minute, the GFR, that's the total volume of blood flow crossing the glomeruli, times the concentration of sodium, or 4 grams per minute of sodium is being filtered, and that's called the filtered load for sodium. And finally, if we know the urine flow rate, we can determine the urinary excretion of a given solute. So for example, if we know that the kidneys were producing 100 cc's per hour of urine and that the concentration of potassium within that urine was 10 milliequivalents per cc, we could then calculate the body's excretion rate of potassium. It would be 100 cc's per hour times 10 milliequivalents per cc, or 1,000 milliequivalents per hour. So I went through all that to help you understand some of the commonly measured variables that we use to assess renal function. And what we're going to do in the next few slides is talk about how we can use some easily obtainable values to get some important measurements of kidney function like renal plasma flow and GFR. So what we're going to try to do is take plasma concentration of certain substances like sodium and glucose, the urine concentration of those substances, and the urine flow rate, and use these to determine the renal plasma flow and glomerular filtration rate. These things are all relatively easy to obtain. We can take a blood sample and measure the plasma concentration of solutes. We can take a urine sample and measure the urine concentration of solutes. And if we ask the patient to collect their urine over 24 hours, we can then determine the urine flow rate in liters per minute. So from these 3 easily obtainable or relatively easily obtainable measurements, we will try to get some important measurements of what's going on in the kidneys like renal plasma flow and GFR. Before we can talk about how to calculate renal plasma flow and GFR, I need to talk about renal clearance. This is a number that is determined for a substance or solute in the blood like sodium or glucose, and it represents the volume of blood cleared of a substance of X. Or another way to look at this is the volume of blood that contained the amount of X that was excreted. To understand this, let's imagine that we have 1 liter of blood inside a container. This container has 1 liter of blood, and within that blood there are 5 grams of sodium. Now let's imagine that the kidneys excrete 5 grams of sodium per hour. Well, it's very easy to imagine that the kidneys are getting rid of 5 grams of sodium per hour. What's harder to imagine is the concept of renal clearance. That 5 grams of sodium was originally contained in 1 liter of blood or plasma. Therefore, the clearance of sodium is 1 liter per hour. What we mean by this is that 1 liter of blood is being completely cleared of sodium per hour because each liter contains 5 grams and we're removing 5 grams per hour. And that's what the concept of renal clearance of a substance or solute means. Renal clearance is reported in liters per minute or volume flow, and it can be determined by the equation shown on the screen. The clearance of substance X is equal to the urinary concentration of substance X times the volume flow rate divided by the plasma concentration of substance X. So what this means is, if we know the plasma concentration of a solute and the urinary concentration, and we also know the volume flow of urine, we can then calculate the clearance of any given solute. One of the most important applications of the concept of renal clearance is in determining the glomerular filtration rate. The GFR is a very powerful measurement that tells us how healthy the kidneys are. As the kidneys begin to fail, the GFR begins to fall. So we want to know what the GFR is for a given patient to determine how healthy their kidneys are, and we can measure the GFR by measuring the clearance of certain substances. The first substance I'll talk about is inulin. Inulin clearance can be used to measure the GFR. Inulin is not naturally occurring and not naturally found in the body. It's a saccharide substance with the chemical structure shown on the screen, and you can administer it to a patient and determine the clearance of inulin to experimentally measure the GFR. The reason inulin clearance can be used to measure GFR is because inulin is neither secreted nor resorbed by the nephron, so any inulin that is filtered at the glomerulus goes out. To make this clear, let's imagine that we have a glomerulus and we've got a certain amount of inulin coming in and a certain amount of inulin getting filtered at the glomerulus. All of this inulin is going to go out in the urine. None of it will be reabsorbed by the nephron, and furthermore, the nephron will not secrete any inulin. So everything that crosses the glomerulus goes out, and that makes the clearance of inulin a measurement of the glomerular filtration rate. So the amount of blood cleared of inulin is the amount or volume of blood filtered by the glomerulus, and therefore the clearance of inulin in liters per minute is equal to the GFR. And as I showed you before, the equation for clearance is on the screen here. The clearance of inulin is the urinary concentration of inulin times the urine volume flow divided by the plasma inulin concentration. And we can measure all these variables in an experiment after we administer inulin to a patient, and then we can determine that patient's GFR. In clinical practice, we never use inulin clearance to determine GFR. Inulin clearance is only used as part of physiology experiments. In clinical practice, what we use to estimate a given patient's GFR is the creatinine. Creatinine is a breakdown product of muscle metabolism, and it is the closest naturally occurring substance to inulin. As I told you before, for inulin, all filtered inulin goes out with no secretion or reabsorption. For creatinine, all filtered creatinine goes out and there is a very small amount of secretion, but this amount is tiny and negligible, and therefore we often use creatinine instead of inulin. Now when you do this, the secreted creatinine will be counted as filtered, and this will very slightly overestimate the GFR, but as I said before, this is a relatively trivial overestimation, and therefore creatinine can be used to measure the GFR. So one way to measure the clearance of creatinine and use that as an estimate of GFR would be to use this equation at the top of the screen here. If you wanted to do this, every time you wanted to know a patient's GFR, you would have to measure the plasma concentration of creatinine, get a urine sample and measure the urine concentration of creatinine, and also ask the patient to hold on to their urine for 24 hours so that you could determine the volume flow of urine. This is very cumbersome and it's almost never done in clinical practice. Instead, what we use is special formulas that convert creatinine to GFR based on variables that are specific to the patient. There are a number of these that are used clinically. One's called the Cockhoff-Gralt. This is shown at the bottom of the screen. It estimates the creatinine clearance based on the patient's age, weight, and whether or not they are female, and the plasma creatinine concentration. So to use this, all you need to know is the patient's age, weight, and gender, and you need a single blood sample to measure the creatinine. You don't need to do all this stuff up here to get the volume flow rate of urine. There are also some other formulas that are sometimes used. One's called the MDRD, and there are many others. Let's talk in a little bit more detail about the relationship between the plasma concentration of creatinine and the GFR. Shown on the screen is the equation for creatinine clearance, which, as I told you before, is essentially equal to the GFR. The numerator of this equation is the urinary creatinine concentration times the volume flow rate of urine. This is the amount of creatinine that goes out per unit time in the urine, and that's equal to the amount produced. Whatever amount is produced on a daily basis by breakdown of muscle mass must be excreted on a daily basis. What this means is that this top part of the equation is essentially constant over time because your muscle mass is constant, you're producing a constant amount of creatinine every day, and therefore you're excreting a constant amount of creatinine over a day. So really, this equation can be changed to look something like this. And you can see from this equation that we've got a constant in the numerator, so anytime the plasma creatinine value goes up, the creatinine clearance will go down, and therefore that reflects a fall in the GFR. So for example, if you double the creatinine from 1 to 2, you would half the GFR. And if you plot this on a graph, you get something like what's shown on this slide here. You can find a graph like this in many physiology textbooks. As the GFR goes up, in other words, as the kidneys are filtering more fluid, the creatinine in the plasma goes down. The opposite is also true, that when the kidneys become sick and the GFR begins to fall, you will see a rise in the serum creatinine. So sort of a general principle of renal medicine and clinical medicine is that in worsening renal function and a fall in GFR, you see a higher blood level of creatinine. And I've written some sample values here on the screen. So patients with normal kidney function usually have a creatinine that is less than about 1.0 or 1.1. For example, 0.8 would be a normal value. Patients with chronic kidney disease can have a higher creatinine like 2.0. These patients have sick kidneys, but their kidneys are still functioning and they haven't progressed to the point where they have end-stage renal disease. Patients with end-stage renal disease who require dialysis can have very high creatinines as high as 4 and sometimes even 5 or 6. For step 1 of your boards and also for clinical practice, you should be aware that the GFR declines with age. Elderly patients like this woman shown on the screen here have a lower GFR than younger patients. This is not always accompanied by a rise in the serum creatinine level. Remember that creatinine is produced by muscle mass, and many patients lose muscle mass with aging, and therefore the serum creatinine may stay normal even though the GFR is declining. So using formulas like the one on the bottom of the screen is very important because they take age into account when estimating creatinine clearance in addition to the serum creatinine level. And this is very important clinically because some medications require adjustment based on the GFR, so you need to take the patient's age into account. So back to our schematic of the various measurements of renal function. So we just talked about how you can determine the GFR using inulin or creatinine. Now let's talk about how we could determine the renal plasma flow. In other words, how much fluid is flowing into all the glomeruli in both kidneys. To determine the GFR, we used inulin or creatinine. To determine the renal plasma flow, we use a substance called para-aminohippuric acid, or PAH. Its chemical structure is shown on the screen here. PAH is not naturally occurring in the body, but it can be administered as part of a physiology experiment, and then we can use the clearance of PAH to determine the renal plasma flow. The reason that PAH is useful for measuring the renal plasma flow is because it is filtered and secreted such that 100% of the PAH that enters the kidneys leaves blood in the urine. This means that the clearance of PAH in liters per minute is going to be equal to the plasma flow to the kidneys in liters per minute. To make this more clear, let's imagine that we have a glomerulus and we have coming into that glomerulus some PAH in the plasma. Some of that PAH will be filtered and will enter the tubules of the nephron, but some of the PAH will not be filtered. But whatever PAH is not filtered will then be secreted by the nephron, and it will also enter the tubules. The net result is that 100% of this PAH that comes into the kidneys will end up going out in the urine, and therefore if you can determine the clearance of PAH, you will be measuring the renal plasma flow. This is different than for inulin or creatinine. Those substances were filtered, but some of them were not filtered, and those that were not filtered were returned to the body. In the case of PAH, this does not happen. Instead, any PAH that is not filtered ends up getting secreted into the urine. So in a physiology experiment, we can measure the plasma concentration of PAH, the urine concentration, and the urine volume flow rate and determine the clearance of PAH, and this will be equal to the renal plasma flow. Now just an aside here, PAH clearance slightly underestimates true renal plasma flow by about 10%. This is because not all of the plasma and blood that goes to the kidneys goes to the glomeruli. Some go to other non-glomerular structures. So sometimes this is called the effective renal plasma flow, and the true renal plasma flow is slightly higher. Let me talk briefly about the difference between plasma and blood. So blood is plasma plus cells and protein. If you centrifuge blood, you will get something like what's shown on the screen here. About 55% of blood is plasma. There's a tiny bit that is made up of leukocytes and platelets, and then about 45% is erythrocytes. For this reason, the renal blood flow is greater than the renal plasma flow, and there are separate calculations to convert a renal plasma flow, like we determined with PAH, into a renal blood flow that includes the flow of the red blood cells. The way that renal blood flow is determined from renal plasma flow is by using the hematocrit. Blood, as I told you on the last slide, is plasma plus cells and proteins, and the percentage of blood that is cells and proteins is roughly equal to the hematocrit. And the hematocrit is an easily